Welcome to our bi-weekly USMLE prep series. I'm Megan, and we're joined by the wonderful Dwan Kinslow. Doctor, how are you doing?
Doing great. How about yourself?
Pretty good. Yeah. So, thank you all for joining us on social media last Thursday as we presented our question to everybody. We had a lot of great responses, putting in their little 2 cents on everything. But yes, so today we're going to kind of take an in-depth look on last week's question. We also have a bonus question at the end, so if you stay tuned, you can answer that one live. Okay. So without further ado, let's hop into this week's question.
Okay, so as always, title slide. What is up, my beavers? Yes, we're well aware that it is an otter, but the joke has been started, so we're gonna keep it going. So
it shall live on.
As always, if you have any questions that you'd like to ask as far as studying or questions about the school, if you're a prospective student even, feel free to email any of these email addresses and we will get back to you as soon as possible. Without further ado, let us see the question. So the question that was asked last Thursday is a 41-year-old woman comes to the clinic with complaints of progressive pain and swelling of her hands in the morning that gets better with use over the past few months. She denies any other symptoms. Past medical history is significant for hypertension and appendicitis, for which she had an appendectomy at 17 years of age. Her hypertension is controlled with lifestyle modification and diet. Physical examination reveals bilateral swelling of the metacarpophalangeal joint and proximal interphalangeal joints. X-ray of the hands reveals joint space narrowing and erosions. Which of the following is the most specific finding in this patient? A, anti-double-strand DNA antibody. B, rheumatoid factor. C, erythrocyte sedimentation rate. D, anticyclic citrullonated peptide antibody. Or E, antihistone antibody.
So we'll give you guys a couple of seconds to jot down what you think the answers are. Just kind of run through it yourself. What key things do you kind of take away from this question so that you could properly address the answer?
So some key factors. So the general that I think of with every single question is going to be the age and demographics. So we have a 41-year-old woman, minus the question already giving us the options of autoantibodies. A middle-aged female, we would want to think about some of the sort of autoimmune disorders that we classically think of. As far as specific to this question, what kind of hints do we have? We have progressive pain and swelling of her hands. That's in the morning that gets better with use. So a big hint of waking up with this and then kind of getting better with use. As well as on our physical exam, we see two specific joints affected, the metacarpophalangeal joint, which is going to be the joint basically at the base of your finger where your finger is connected to your hands, if you weren't already aware. And the proximal interphalangeal will be the next joint out, so your first knuckle that's actually on the finger. Those two joints are classically affected in the disease process that this patient has. And lastly, our X-ray result is going to show joint space narrowing, which pretty much just tells us arthritis, but the thing we see here that is kind of a key is that there are erosions present. So all of those things kind of combined give us an idea of what the diagnosis of this patient is, and then from there we can figure out which antibody is responsible for those symptoms.
So looking back at social media, a lot of people wrote in saying they thought the answer was D. Oh, we have somebody in the chats right now. Thank you guys so much for responding. Yeah. Okay. So let's find out what the answer is.
So the answer is actually going to be anticyclic citrullonated peptide antibody. So our patient has rheumatoid arthritis. It's kind of given away by the title of the PowerPoint, but either way, all of those clues were to hint us towards rheumatoid arthritis. So let's talk about rheumatoid arthritis a little bit. So rheumatoid arthritis is a chronic inflammatory autoimmune condition that is most commonly in women. So hence why I was saying, that middle-aged female patient, you do want to kind of suspect autoimmune diseases such as rheumatoid arthritis, lupus, things like that. The presentation, it's mostly an articular disease process, so it's going to affect your joints, usually symmetric, so on both sides, and it's going to be polyarticular, so affecting multiple different joints. You're going to have pain and swelling in the hands. Classically, you see involvement of the metacarpophalangeal and the proximal interphalangeal joints, as opposed to rheumatoid or osteoarthritis, the classic age-induced arthritis that most of our grandparents probably have. And that's going to be the PIP and distal interphalangeal, so the joint just before the tip of your fingers. Also classically affected elbows, knees, ankles, but really any joint in your body is possible. The pain is usually present upon waking, and they'll have the pain, swelling, and stiffness in the morning for longer than an hour. Again, compared to osteoarthritis, which usually is less than an hour and gets worse with use, rheumatoid arthritis is actually going to get better with use. So you wake up for an hour or more in pain with stiffness, but as you go throughout the day, it gets a little bit better. Other things you can see, systemic symptoms, they might have a low-grade fever, fatigue, weight loss, generalized weakness, things like that. But those don't really clue you into any specific disease. On labs, the classic one that we learn in medical school is that rheumatoid factor is going to be positive, but rheumatoid factor can be positive in lots of autoimmune diseases and isn't specific for rheumatoid arthritis due to the fact that it can be present in a lot of different disease processes. Anticyclic citrullonated peptide is going to be the one that is specifically for rheumatoid arthritis. So if this antibody is positive, then you want to think that rheumatoid arthritis is your diagnosis, as well as C-reactive protein or ESR can be elevated as well. But those are just markers of inflammation and also are going to be present in plenty of disease processes, anything that can cause any sort of inflammation. On the imaging of joints of patient with rheumatoid arthritis, like I said, the erosions are kind of one of the big giveaways, just because you do have those antibodies destroying your joint space. Joint space narrowing, which is common for just arthritis in general, and soft tissue swelling as the surrounding tissues can be affected. The other option, so anti-double-stranded DNA is going to be for lupus, which again, similar age range of middle-aged women, you want to kind of think about this. But the presentation is a little bit different. So systemic symptoms like fatigue and malaise. Rashes, classically, we think of the butterfly rash or malar rash that goes across the nasal bridge and under both of your eyes. Arthritis will be present for that as well, but you classically will see anemia, pericarditis, and sometimes seizures associated with that as well. For rheumatoid factor, like I was saying, is present in rheumatoid arthritis, Sjögren's syndrome, another autoimmune disease, and other processes that aren't listed here. But it is just an IgM antibody against the Fc region of an IgG antibody. So it's one antibody against another antibody. Not very specific to any one disease, even though it is named rheumatoid factor, and classically we associate it with rheumatoid arthritis. ESR, like I said, was inflammatory marker. So it's going to be present in lots of diseases. Plenty of them are listed here: temporal arteritis, polymyalgia rheumatica, infections, Takayasu arteritis, rheumatoid disease, malignancy, infection. Again, not specific to any one disease. And antihistone autoantibody is going to be specific for drug-induced lupus. So like systemic lupus erythematosus, you'll have a similar presentation: fever, polyarthritis, myalgias. You can have infection of serosa, so pericarditis, pleuritis, things like that. And then some of the medications that can cause that are listed here. So procainamide, hydralazine, isoniazid, but there are plenty of other drugs that can cause that. So please go ahead and familiarize yourself with some of those other ones. So just some complications of rheumatoid arthritis we want to think about. Cervical subluxation, so that is where you have slipping of your vertebrae on top of each other, which can compress the spinal cord and cause lots of problems. So cervical being in the neck. Classically, especially as far as questions go, we see this in people with rheumatoid arthritis who get into a car accident or some sort of trauma, or even undergoing for surgery, and they get intubated, and then they wake up paralyzed and with respiratory issues and things like that, because it's the same as kind of severing your spinal cord at the neck. Everything below is going to stop working. Some other things we can see in the hand, ulnar deviation of the hand. So if you've ever seen an old person in their hand, it's like if their hand is up and their fingers are going the complete opposite way, that is a late manifestation of rheumatoid arthritis.
Okay.
And then swan neck and boutonniere at your PIP, either when you try to straighten your finger, it'll either be still slightly flexed or it'll be hyperextended. I believe hyperextended is swan neck and boutonniere is slightly flexed. Look up some pictures of those. It's kind of interesting. We might know people who have these kinds of deformities, not having rheumatoid arthritis, but it's an interesting picture to see. If you have first aid, there's good pictures in there. If not, simple Google search, you can get some good looking pictures. But as an autoimmune disease, it can affect lots of other things. You can have nodules pretty much anywhere in your body. If you have it in the lung with a pneumoconiosis, it's called Kaplan syndrome. You can have interstitial lung disease, inflammation of the tissue surrounding your lungs, pleuritis, inflammation of the tissue surrounding your heart, pericarditis, anemia of chronic disease, decrease in white blood cells, and a swelling of your spleen is called Felty syndrome, amyloidosis, so distribution of proteins throughout the body that causes symptoms, Sjögren syndrome, dry eyes, dry mouth, scleritis, carpal tunnel syndrome. So lots of things can go wrong in association with rheumatoid arthritis. And with all autoimmune diseases, you also want to think about the fact that there's a possibility of other associated autoimmune diseases. So, speaking of what I like to go into next, now that we've talked about how to diagnose and how it presents, I like to go into treatment. But, like Megan had mentioned earlier, we have a bonus question for you. Which of the following is the most appropriate treatment for the patient's symptoms? So we had the female who was having the stiffness in the morning that was better throughout the day. She's having the joint erosions and joint space narrowing on X-ray, and she's got swelling and tenderness of her metacarpophalangeal and her proximal interphalangeal joints. So what would we want to give this patient? A, NSAIDs, B, methotrexate, C, palivizumab, D, naproxen, or E, tamoxifen.
We'll give you guys a couple seconds to comment your question or your answers. Put in your 2 cents on what you think the appropriate diagnosis would be, and yeah. Hope you guys like the bonus questions. We tend to not do a whole bunch of bonus questions, but I think they're fun to interact and keep them on their toes.
Yeah, and definitely sometimes when you're doing questions on your own or taking your exams, you will get these 2-part questions where you can't go to the second one until you've locked in your first answer. So usually the second question is a continuation like this one. Obviously, in the first one, they didn't explicitly state that the patient had rheumatoid arthritis. They hoped you figured that out and would get the antibody. And then the second follow-up would be, how do you treat it? So instead of them giving you the answer, they want you to kind of think about what all is going on. And critical thinking is very important to medicine.
It is. I mean, you gotta know how to balance from one thing to the other, and keep it all going.
Yeah, you gotta know when to hold them.
When to show them.
Fold them.
Ah, so close.
You tried.
I tried. I forgot that song.
I appreciate that you even caught on and went along with it.
Wasn't there a commercial too?
I think so.
It was like a
I feel
Snickers
it was,
commercial, or
yeah, maybe M&Ms. My first thought was it being a Bud Light commercial for some reason.
oh no, I think it was candy.
Sounds
Well,
a little more right.
if you know that answer, you can put that in as well.
Halloween time.
It's
Gotta know when
Halloween.
to hold the candy and when to fold the candy.
You know,
Trick
typically
or
when
treat.
smaller children say, "Please give me candy."
Do children say, please give me candy? I feel like they just kind of
No.
go, trick or treat.
They're like, "Here's a sack."
Here's a toothbrush. Shout out to all the dentists out there.
You know?
So I think we've given enough time on this
The
question.
panderings.
So it was mentioned in the chat. So we do want to give this person a DMARD. So the answer is going to be B, methotrexate. So we already know that it's rheumatoid arthritis from the previous part of the question. NSAIDs are a good treatment for rheumatoid arthritis when it's earlier on, and is good to help with symptoms and help prevent some inflammation. Some of the NSAIDs were listed here. Naproxen is one, aspirin is one, indomethacin. Steroids are good because they basically will shut off your immune system. So obviously, if you're having an autoimmune disease, your own immune system attacking you, shutting that down is good, but using long-term can affect the body in worse ways. So it could be a short-term treatment of like an acute exacerbation of the disease. But disease-modifying anti-rheumatic drugs are going to be usually the more long-term treatment, especially if the patient is having a more severe disease. So in our patient, we saw the erosions, the joint space narrowing, things like that, that would indicate that this disease process has been going on unchecked, and it has caused severe damage to your body, to your joints. And that's when you want to do a disease modifying. So if you think about a disease as progression, if you catch it at the second to last stop, if you think of it like a metro train, well, you want to modify that and turn that train around and get as healthy as you can in that point. So some examples, methotrexate, which was the answer here, sulfasalazine is one. There are TNF alpha inhibitors such as infliximab and adalimumab. So depending on where your patient is at in their symptoms would kind of depend on what's going on. If this patient had been like 20 and just now noticing like for the past couple of days, they were waking up with like the swelling and pain, stiffness kind of thing, then that would be more of a time to kind of start with the NSAIDs to try and get ahead of the disease process as opposed to the DMARDs, because the DMARDs do come with side effects that some people aren't as willing to go to, but that's generally why it's reserved for more severe disease. We do have a question asked in the chat. So what tests should you do before giving the TNF alpha inhibitors? So before giving most of the anti-autoimmune drugs, but more specifically TNF alpha inhibitors, you do want to do a tuberculosis test to make sure that they don't have silent TB, or basically just they've had TB at one point and now it's just dormant in their body. If you inhibit TNF alpha, that allows those TB to kind of reactivate and basically to start reproducing again and cause a secondary and more serious infection than the primary would have been. So if it comes from an area that TB is prevalent in, or if they have a known history, generally in those patients, you can't give them TNF alpha inhibitors at all. If you don't know whether or not the patient has, then the best thing you can do is to test for that in order to make sure that that's something you're not putting the patient at risk for of reactivating their TB. That was a good question. Thank you. Thank you for the chat. The other answer choices that we haven't talked about, palivizumab is a monoclonal antibody that's used against RSV. Knowing that a patient has rheumatoid arthritis rules that one out. To my knowledge, there aren't any broadly advertised monoclonal antibodies used to, adalimumab and infliximab. Ignore what I just said. Anyways, it's used for RSV, so it's not one that you would use for RA. It would be inappropriate to do that one. Tamoxifen is a selective estrogen receptor modulator. It's used for breast cancer treatment or prophylaxis if somebody has like a BRCA mutation in their family where, grandma, mom, aunt, pretty much everybody has gotten breast cancer. You can kind of either start treating them with that earlier or especially after they've gotten like a mastectomy. It's good to kind of help prevent recurrence and not put them at risk of uterine or ovarian, having that unopposed estrogen. So that is rheumatoid arthritis in a nutshell. It's like maybe not the whole nutshell, like half a nutshell, like a walnut.
Those are hard to crack.
Yeah.
Oh, well, there you go. Well, thank you so much for joining us today for our USMLE Prep question and answer series. We hope to see you next Thursday on our social media pages for a new question, and then we will be back that following Thursday to go live with you guys again. So thank you so much. We hope this was informative and that you can take something away. And, there's our side talk here and there as well, just to, give you guys some time to respond. But yeah, have a great day, everyone.